Thank you, Chelsea. I appreciate that. And I'm very happy to be here tonight in order to talk to everyone about BPH. It's become one of my most enjoyable things to treat. Just as a way of history, I started doing urology in the late 80s. And back then when we did it, unfortunately, we had nothing to offer patients other than a TURP, or what's called a transurethral resection of the prostate. So when patients came in, if they had problems, we didn't have any medicines or any good medicines back then. And it was more frustrating. But to see where we've come in the last 30 years is really amazing. And I hope that I can share with you tonight some of the really scientific advancements that we've been able to do in trouble with urinating, because I do think it's a very significant problem, as I'll show you later. And to be able to offer some wonderful treatments now with minimal side effects has been a great advancement. I'm happy to have been a part of this. So the first thing we're going to talk about tonight, in fact, the only thing we're going to talk about tonight, is BPH and how it's diagnosed, how it's treated, what we can do for it, and those types of things. But one thing we're not going to talk about is prostate cancer, and I'll get to that in just a minute, or any other prostate conditions. We won't be able to have time to talk about prostatitis or prostate infections or prostate cancer. That's another important topic, but we won't be able to get to that. The prostate starts out as a walnut-sized gland, and it's at the base of the bladder. My favorite analogy in this is to think of a funnel and a donut. So the funnel would be the bladder and the urethra, and then the donut slipped onto it would be the prostate. It is circular. It does encompass the entire circumferentially around the urethra. And people always ask me, what's the purpose of the prostate? And it's to produce fluid that helps keep the sperm alive and to help transport the sperm during ejaculation. Now, there's three things that continue to grow in a man's life throughout his entire life, and it's ears, nose, and prostate. So the prostate starts growing somewhere around your mid 30s to 40s and continues to grow throughout your life. It never, ever stops growing. We don't really know why. People have done a lot of experiments and investigation into this, but nobody really knows why the prostate continues to grow, but certainly it does. And if you look at the percentage of people that are bothered by an enlarged prostate, you can see that in your 50s, about 40% are bothered. And then as you get your 60s, 70%, and by age 80, about 90% of men are having trouble with urination. And if you look at the numbers now, with 300 million people in the United States, half of them are men, and you have a large percentage. This obviously is a huge problem. Now, again, this is a term for benign enlargement. Okay, so benign enlargement means it will grow and grow, but will never spread. It's not cancerous. It will not kill anyone. It will not spread to other areas of the body. So it is a non-cancerous growth. Now, and it's not a predictor of whether or not you have cancer or not. In fact, I've seen extremely large prostates that don't have cancer. And in fact, there's always been some research showing that the larger the prostate, sometimes that reduces the risk of having cancer. So just because someone is told they have an enlarged prostate has nothing to do with whether or not you have cancer or not. In fact, the PSA, the blood test for prostate cancer, also increases with the enlargement and growth of the prostate, which makes it difficult sometimes to determine if someone's PSA is elevated due to an enlarged prostate or due to cancer. And so that's what we deal with on a daily basis. But we have to differentiate those two things. Now, as the prostate enlarges, it pushes pressure or a constriction of the urine outflow. You can see in these diagrams below that as the prostate, this is a prostate that's minimally enlarged, and there's a nice open channel. But as the prostate enlarges, you can envision that there is a slowing of the stream, blockage of the flow. And it's not just the prostate that changes during this time. The bladder can actually change. Just as if you lift weights or do exercises, your muscles will grow. The bladder will do the same. It will grow and will become hypertrophied because it's pushing against an obstruction, similar to if you're pushing against weights or lifting weights. Unfortunately, however, this hypertrophy or strengthening of the bladder leads to problems, whereas skeletal muscle, which is our muscles in our arms and legs, those muscles get stronger and bigger. This becomes more irritable. When this bladder, which is called smooth muscle, which has smooth muscle in it, becomes more irritable. So it causes people to have urgency and frequency of urination, making them get up at night several times. And we'll get into that to talk about the symptoms that enlargement causes. Interestingly, however, the size of the prostate doesn't necessarily correlate with how much trouble someone will have with urination. I've had patients have prostates the size of softballs and have absolutely no problems, and men with prostates that are the size of a walnut and have terrific trouble. So we really don't know all the time about why the prostate causes obstruction in some people and not others, but certainly it's quite variable whether or not someone has problems or not. Now here's some diagrams of what could happen, some schematics. And on the top films, you can see what a normal prostate looks like. The bottom films are what it looks like when we put a scope up through the penis to look at the prostate. In the initial one, when there's no obstruction, there's an open channel. As the prostate becomes more hypertrophied or enlarges, you can see the blockage. And then as it gets worse and worse, you can see this tissue here that is really obstructing the prostate and obstructing the bladder and obstructing the urine flow. And of course, I think we all know, including myself, what some of the symptoms are: frequent urination during the day, getting up at night in order to urinate, sudden urges to urinate, and then of course the obstructive symptoms, which would be trouble getting your urination started, slow streams, starting and stopping, and dribbling at the end. Now, there is a real cost to having BPH and an enlarged prostate. It's not just that you have these symptoms, but it can cause a real deterioration in the quality of life for men. Many men won't travel. They'll avoid going to certain places, going out to dinner, going out to sporting events, theater. They'll really change their lifestyle because of the problems that are happening. And in fact, one of the worst things that can happen is disruption of sleep patterns. There's been a number of studies that have shown the increased number of times that you get up to urinate and lose sleep is correlated with poor work performance, sleepiness, drowsiness, anger issues, those types of things. So it's not just the fact that it's a bothersome, it really can affect the quality of our life. And most men, or many men, about half of the men in the United States will actually seek treatment for an enlarged prostate, which leads me to say, I'm not sure why the other half aren't, but maybe they're afraid or concerned about it, but there certainly are a number of excellent treatments available. Now, the enlarged prostate does lead to bladder, what we call BOO, or bladder outlet obstruction. That means that there's a decrease in the ability to empty the bladder. And this certainly can cause what we talked about just a few minutes ago about bothersome symptoms and interference with activities and those types of things. But it can also lead to serious medical problems. Having an enlarged prostate, not being able to empty the bladder well, can cause urinary tract infections. It can cause a man not to be able to urinate at all. It can also cause stones to occur in the bladder. And in its worst situation, if we're not emptying the bladder and the pressure builds back up onto the kidneys, it can lead to renal damage and even renal failure. So there are some serious complications and consequences that can occur due to enlarged prostate, not just the bothersome symptoms. The way we diagnose it is in a BPH or enlarged prostate is we talk to the patient, we find out what symptoms they're having. We usually do a rectal examination just to feel the general size and to rule out any nodules that might be consistent with cancer. And then we usually ask the patient to fill out a questionnaire. It's called the AUA symptom score, and it's a series of questions that ask how bothersome are your urinary symptoms, and it adds up to a certain score, anywhere from 0 to up to 30. The higher the number, obviously, the more bothered the patient is. And really, this is such an important thing, and I want to spend a minute on this, that bothersomeness is very, very important in this situation. And the reason it is because most of the time, men are not going to lead to some of those problems like infections and retention. Most of the time, it's just going to be a bothersomeness. And if someone isn't bothered by their prostate and has only minimal symptoms, there is really no need to intervene. But if there are bothersome symptoms, and that's when we really like to intervene, assuming there's not any of those more major problems that I talked about before. There's some other studies we often do. One is called a Urethral. It's where we have the gentleman come into the office with a full bladder, and we'll have him urinate into this funnel type system. And it tells me how fast and how strong the stream is coming out. And that can give me a general quantitative aspect as to how poor the situation is. We sometimes do an ultrasound of the prostate to get a generalized idea about how big the prostate is. That can lead to help us in order how to treat a patient. And then cystoscopy. This is where we put numbing medicine up into the penis, and we take a lighted fiber optic scope up through the penis, and we can actually visualize the prostate like I showed you in some of those pictures before. Now, how are patients treated with BPH? It's quite variable. A large number of men will not do anything or do not seek treatment for it. Other people, about 60%, will want to use drugs or medications, but only about 3% of people actually elect surgery. And I think that's because people are frightened of surgery. They've heard of bad outcomes. They've heard of friends and family that have had complications from the treatment. And most of that's from using the tried and true method, which is called a TURP, or a transurethral resection of prostate. That's where we take you to the operating room and put you to sleep with general anesthesia or a spinal. And we go up through the penis with a scope and basically erode out the tissue. And we actually use a device that kind of takes little slices of the prostate out from the inside out and removes the tissue, and that tissue is actually removed. It's a wonderful treatment. It's been going on probably for 80 years, but it does come with some complications and risks that we will get into in just a moment. When we look at all the different treatment options, we can go anywhere from watchful waiting, which means do nothing, to medications, to some of the other therapies we're going to talk to, and including the Roto-Rooter or TURP procedure that I mentioned before. Now let's go through some of these. Watchful waiting is a wonderful treatment option because it doesn't have any risk to it. There's no surgery, and you really don't have to do anything. The problem is you probably will not get symptom improvement. And then that risk actually increases over time if you just watch your condition. This is kind of what can happen when we do watchful waiting. So on the left side picture, that's a picture of what a normal bladder would look like. As time goes on, there is what's called fibrosis or trabeculations of the bladder. And then eventually it gets to deep, thick trabeculations and scar tissue and fibrosis in the bladder that can lead to permanent damage. And in fact, if the obstruction continues for years and years, it can lead to permanent damage that's not reversible. There have been multiple studies that have shown the earlier that intervention is done for an enlarged prostate, the better outcome that occurs. And in fact, one study showed that 87% of men who watched their prostate, they had a worsening over 4 years. And another study showed that the earlier that patients had intervention with the old TURP, the better their outcome ended up being. Now, there are medications. In fact, many of us, including myself and a lot of you out there, I'm certain are on medications, and there are a lot of advantages to them. There is no surgery. They can provide great improvement and relief in urinary symptoms, but there can be some problems with it. You should have to take the medicines every day. People often ask me, how long do I have to take the medication? I say, as long as you want to have the symptom relief. Because if you stop the medication within time, you will go back to where you started from. And there's always potential side effects to medications. One set of medications are called alpha blockers, which are medications to relax the prostate. These can come with symptoms of dizziness, lightheadedness. It can come with ejaculation problems, and what's something called retrograde ejaculation, which means that when a man has an ejaculation, the fluid doesn't come out of the penis, it goes back up into the bladder. Now, that's not dangerous from a medical standpoint, but from a sexual satisfaction standpoint, many patients are bothered by this. Other medications, including medicines like Proscar or finasteride, actually shrink the prostate, which is nice, but they also come with risk. And those can be breast soreness, enlargement and tenderness of the breast, ejaculation and erection problems as well. And over time, these medications may stop working. So these may be a solution for many people, but certainly not everyone. People always ask me about herbal medications and remedies, and the American Urologic Association has taken a strong stand in this, and they've come out to say that there has never been a study to show that any of the herbal medications actually are successful in treating this. And there's I think, a lot of problems with herbal medications. These are not regulated, as you know, by the FDA, so anyone could put anything in a bottle and claim that it does help with this. But again, there really hasn't been any studies to confirm or show for sure that these actually work. I know lots of patients tell me they do work. There may be a placebo effect to some of these. In fact, all prostate studies that are done have to have a placebo. And the reason for that is that the placebo shows about a 33% improvement. So anything I give a patient will have a 33% improvement, even if they're given a placebo. So we have to be very careful with the improvement that can come from herbal medications. And a lot of patients are not satisfied with drugs. 50% of people are satisfied with medication. The other 50% really aren't. And almost 2/3 of men are actually interested in an alternative to medication. If you're like me, I don't like to take medications unless I absolutely need to. And so that's why, some of these alternatives have become the necessity of getting other procedures is because the current treatment methods are not successful. So, and then I failed to mention that some of these medicines to shrink the prostate, like Proscar and Avodart, those medications take a minimum of 6 months to work, and usually a year. So medications are helpful for many, but not necessarily for everyone. Now, I mentioned earlier in the talk that before, when in years past until more recently, major surgery was really one of the only alternatives to medications. And that means going to the operating room and having anesthesia and going up through the penis with a scope. And there's multiple different ways that we could open up the prostate and open up the channel. There's a laser procedure. There's the transurethral resection that I mentioned to you earlier, where we actually scrape out or open up a big channel. And there's a lot of advantages to this procedure. It's a tried and true method. We've been doing it for probably 70 to 80 years. And it maximizes the flow. It certainly gives you a much, much better relief than any of the medications could. It actually removes prostate tissue. The effects of it will last a long time. And very few people need to go back and have another treatment after this. So that is really has a lot of advantages in that sense, but there's a lot of disadvantages. And that is, again, it's under anesthesia. You have to be hospitalized overnight. And there are the risk and possible complications. There is about a 10% risk of losing erections. There is at least a 50% chance of losing ejaculations. There's a 1 or 2% incontinence rate. And then there's scar tissue that can form, strictures, scar tissue that form in the urethra, the tube that a man urinates out of. And so if this was a 100% effective type of procedure, these other methods that I'm going to discuss would never even be necessary. But unfortunately, there have been some problems with this. An interesting side effect is that, or side point is that this procedure is probably the hardest operation that we as urologists learn. I remember when I was doing this at the VA hospital, we didn't really feel like we had a good feel of how to do this operation until I did about 75. And then after 100, you felt much, much more comfortable. At 125 operations, and this is the same operation, you started really feeling very comfortable. I worry about the next generation of urologists that comes out, because they're not getting the chance to do that many of those operations, because there's so many more alternatives. I fortunately trained at a time where there wasn't alternative, so I got to learn this operation very, very well. But I think the new generation of urologists are probably not going to have that same amount of training. So again, surgery is a big step. It's anesthesia. You have to wear a catheter for several days. The recovery can take up to 4 to 6 weeks. And again, there are the, those complications that I mentioned. So the first real big change that I feel happened occurred about 5 or 6 years ago, and it's called the UroLift. And you may have heard about this procedure. It's a non-drug therapy. It's a procedure that we can do in the office, and it really provides rapid relief of symptoms within a few days. And the wonderful thing about this procedure, it has absolutely no risk, no long-term risk. There is no risk of ejaculation problems, erection problems, or leakage. So there really is no risk. And I love offering a treatment like this to patients when I know I can tell them that you have a great chance of being better, but a 0% chance of being worse. So I really think that's wonderful. Now, as I said, this is an in-office procedure. It preserves sexual function. The results and the improvement usually occur within 3 to 10 days afterwards. And typically we only leave a catheter just overnight. When I do these, I do them on Wednesdays in my office. We leave a catheter until Thursday morning. So there's a very short catheterization period. Now, there are some side effects to this and some irritations. Once the catheter's out for 3 to 5 days, patients typically have burning with urination. They may have some blood in the urine. There can be some urinary urgency where you have a sudden urge to be able to urinate. But these are quite transient, and within about 3 to 5 days, they usually are resolved. What we use in this procedure are these little things called anchors or transprostatic tissue retractors, and they're actually implants. And what they are is there is a nitinol implant here that goes on the outside of the prostate, or if you want to use the donut and funnel analogy, this little tab will be on the outside of the donut, and this tab will be on the inside or in the donut hole aspect. There's a suture that goes between them, which pulls the prostate open. And I'd like to show you some of that, how this actually works. When you look at this, these anchors or clips are quite small. They're only 8 millimeters, which is about a third of an inch. This is the part, the stainless steel goes inside the urethra on the inner aspect of the donut, and this latches onto the outside of the donut. This is an artist's rendition of how this procedure works. We put a scope up through the penis. We push the prostate lobe inward. That's what this shows. A little device, or what we call a little metal prod, will go through and will deposit this first anchor on the outside of the prostate, and deposit the inner anchor or the nitinol anchor there, and you can see how it pulls the prostate open. So this is the first clip that was put in, and this is after putting in 4 clips, and you can see the difference between here and the open channel that occurs. So it compresses the lobes of tissue, or the prostate lobes, and compresses them outward in order to open up a channel. Typically, we put about 4 implants in, anywhere between usually 4 and 6. The actual procedure takes about 5 to 6 minutes, and I use nitrous oxide or laughing gas in the office to help with relaxation and discomfort control. This is an animation of how the clips are placed, and I think it's helpful to describe this. So there's the compression, there's the metal prod that goes out, the deposition of the anchor on the outside of the prostate and on the inside. And you'll see how it's done in 4 different areas. And it shows the opening of the prostate. And there's the before and after picture. And this is a endoscopic view. This is what the scope would look like before and after. Now, so this mechanically opens up the prostatic urethra, and this is the actual visualization. This is actual film or pictures of the prostate before we do the procedure, and this is after, and you can see a nice open channel. And we can actually see this while we're doing the procedure, which is wonderful because I can actually see where I need to put clips, how many clips need to be done, and make sure things are open. The implants are put away in a different area where the nerves for erections travel, so you don't have any chance of having erection problems or heavy bleeding. Now, this is a study, it's called a LIFT study that was done years ago to show the effectiveness and the improvement in urination that occurs with this procedure. This is that IPSS score. This was the score I was telling you about earlier, where these are the actual symptom score. So the average was right around 22 or 23. And within several weeks to a month, the symptom score goes down to 12. So it's a tremendous improvement in urinary symptoms after the procedure. And these symptoms are these symptom scores include things like how often do you go, how urgently, how does your stream come out, how many times you get up. So this is the symptom score. It goes down quite rapidly, and it's durable. This is data at 5 years after the procedure, and it shows the symptom score and the quality of life improvement that persists even up to 5 years. People often ask me, how long do you think this is going to work? And the answer I tell them is, we know it works up to 5 years because we have this study, and we believe it's going to last a lot longer, especially since, remember, prostates grow over decades. They don't grow over days or months or even years, decades that these prostates grow. So if we can reverse this 20 to 30 years, this treatment may last an awful long time, and we certainly can redo it at any time. Now, the surgical retreatment rate is quite low for this. The UroLift retreatment rate is only about 10 or 15%, which is actually quite good. This is a tuna procedure where we used to put radio frequency waves into the prostate, and this is a microwave therapy. And you can see that the retreatment rate is much, much higher, and the improvement is much, much worse than the UroLift. Again, there's minimal morbidity that occurs after this procedure. Certainly, a great majority of patients have burning with urination, some blood in the urine, even some minor pelvic pain that we've seen, but that resolves quite early after the procedure. And again, there's no incidence of incontinence, impotence, or ejaculation problems. 86% of the people achieved a high quality recovery within 1 month. And the satisfaction score of this is extremely high. Patients ask, when can I go back to doing golf and tennis? And the answer to that is the next day. There are no limitations to what a person can do after this procedure. So it's an immediate return to work and activity. Most patients at 5 days are back to complete recovery after this. Very little work missed, and very, very high tolerability of this procedure. And again, it avoids erectile dysfunction, ejaculatory dysfunction, and that type of a thing. Now, if you compare this to medicine, the UroLift has a significantly better improvement in your symptom reduction. So this is a table of the prostate symptom score that we talked about. This is with Proscar, or the prostate shrinking drugs. This is with the alpha blockers or the relaxing drugs. And you can see that the UroLift works significantly better than medications alone. And you can see the side effects. This is the incidence of sexual dysfunction can occur in 10% with the relaxing medications and about 4% with the shrinking medication. So it does work better than the medications and with less side effects. Now, I've done about probably 350 of those UroLift procedures and absolutely love them, but it's not the treatment for everyone. Those UroLift procedures seem to work very, very well on prostates up to about 50 cc's or cubic centimeters in size. Above 50 or 60, they work okay, but not as well as they do on the medium size enlargement. Another treatment, this came around about 4 or 5 years ago, is another treatment that I've adopted because I felt that not everybody was able to be treated with the UroLift. And in fact, the bigger glands weren't. And this is a therapy that I've been using on glands that have been between 50 and all the way up to about 150 cc. So I've actually used these on some fairly large glands or very large glands. This also is a treatment that I can do in the office with nitric oxide or laughing gas. And what this involves is injection of steam, actual steam into the prostate. And there are 9-second treatments. So we look up inside the urethra again with our scope, and there is a little prod that I advance into the prostate itself and inject steam for 9 seconds. And we'll inject those 9-second treatments anywhere from 6 to 8, all the way up to 14 little individual treatments, all done at the same time or sequentially during a 5 to 7 minute procedure. So again, nitrous oxide, it's a scoping procedure. I'll inject 9 seconds in treatments in anywhere from 8 to 14 different areas. And that steam actually kills prostate tissue. And when it kills the prostate tissue, the body will, over the next several months, reabsorb that killed tissue, and it will lead to a shrinkage of the prostate and an improvement in urinary symptoms. This is clinically proven results. And it's able to treat larger prostates and even prostates with what we call the median lobe. Prostates can grow and enlarge from the sides, but they also can grow with tissue coming up from above. And when that tissue goes up from above, it's more difficult to treat. And this actual treatment of Resume can tackle that issue as well. Here's the device. You can see the handle, and that scope will go up through the penis. There's a generator that heats up the fluid and allows me to inject the steam into the prostate. I'm not sure, this is actually an air that doesn't take 2 hours. It takes, again, about 5 to 7 minutes. For both the UroLift and the Resume, I give patients ibuprofen and Tylenol an hour beforehand, along with the nitrous oxide or laughing gas to make the procedure comfortable. Again, it takes about 5 minutes and the 9-second treatments. Now, we do have to put a catheter in, just like with the UroLift, and I do need to leave the catheter in for 4 to 5 days. And the reason is that when you already have an obstructing prostate and you inject steam in there, the prostate tissue gets irritated and swollen, and the body doesn't like that. And so the body brings in all its anti-inflammatory type of cells, and it actually makes the prostate more swollen. And if it makes it more swollen, there's more difficulty urinating. So in the first 4 to 5 days, we do need to put a catheter in, just allow the bladder to drain. We give medications to help tolerate that catheter, and the catheter then comes out about 5 days later. This is actually an actual picture of a patient who had this procedure done. And if you can see on the left side, this is actually what's called a median lobe, where I was telling you how your tissue comes up from underneath. And this tissue, even a small amount of tissue coming from the middle lobe, or median lobe as some people call it, can cause an awful lot of obstruction. And this is the same patient 6 months after the Resume, and you can see what a nice open channel and great relief that occurred for this patient. Interesting list. These are MRI views of the prostate. This is what happens at 1 week after we inject the steam. And then over time, you can see that this tissue is opened up. And when you look at this, the actual prostate reduction, the reduction in the actual prostate volume could be about 30%. So you're actually removing about 30% of the prostate, which is a lot, because the tissue we're removing is along the urethra, the tissue that's actually obstructing. So the improvement can be extremely satisfying in this kind of a procedure. Again, we're going back to that IPSS score that tells us what kind of improvement we're going to get from this procedure. And if you start up at the 22 range, just like the UroLift, you can see at the end they're down to 10 at 3 years, and it's a really nice improvement as can occur with UroLift procedure. And again, this is the improvement in symptoms. And quite frankly, there's many other modalities that we looked at to see if there's improvement. We can see if the stream comes out faster. We can see if the patient's emptying their bladder better. But really, in 95% of the patients, the reason we're doing this procedure is to help people's symptoms. And that's why we keep going back to this IPSS score, because that tells me that the patients are happy and pleased with the thing. Now, again, there are side effects from this. Burning with urination is very common. Blood in the urine, having to go frequently, urgently in the first few weeks after the procedure does occur. But again, over time, these resolve, and we do give medications to help in tolerating this. Now, you'd think that with those two procedures that we would be done and happy and not have to come up with anything else. But these procedures, as good as they are, and they are wonderful in the sense that we don't have to really remove a lot of treatments. You don't have to resect and do the old rotor-rooter job. And they have a wonderful safety profile. I mean, the safety of these procedures are tremendous. But the symptom relief is very, very good, but it's not as good as the old rotor-rooter or TURP operations. And that's why this next device that I'd like to talk about, and the final one, is called aquablation. That's why this was embedded. So aquablation can actually treat any size prostate. As I mentioned earlier, the UroLift, I like to do up to 50 or 60 cubic centimeters. The Resume can go up to maybe as high as 150, but really about up to 100. But this aquablation treatment can actually treat almost any size prostate. And it's independent. The results are independent on the size of this. Now, this is the device here. Interesting, we had a patient donate this to the hospital, which was wonderful. And the benefit of this is that we have the improvement, the wonderful improvement that comes with the old TURP, but it has a lot more improvement in the safety profile. Because as I mentioned before, on the rotor-rooter or TURP procedure, there's a risk of scar tissue, incontinence, loss of erections, and loss of ejaculations. But this procedure gives the long-term symptom relief without the risk of all the old previous transurethral resection or TURP procedure. Now, I'd like to use this video because this is, again, it's a technological marvel on how this works. Let me go through this with you, and it's going to take a few minutes, but I do think it's worthwhile going through this. And what this procedure does, it combines aquablation. It combines the camera, using a camera so we can see where we're at, along with ultrasound imaging. So when we do this procedure, again, this is in the operating room under general anesthesia, we put an ultrasound probe into the rectum to give us images of the prostate. Then we put a scope up through the penis, and it allows us to actually look and see what we're seeing. Now, this is the actual view, and this is the artist demonstration. So with the scope in the penis and the prostate ultrasound, we are watching it in two different fashions. And this is what happens here. During the procedure on the ultrasound view, we can actually put the dots where we want to resect the tissue. So we are telling the machine and the robot what to remove and what not to remove. And so you saw there, we moved the little dots in so that we would allow us to put the dots where we want to resect it, a more safer area. Now, we look at the prostate with ultrasound in two different dimensions. We look at from a longitudinal and a transsectional area. So again, we're telling the computer, we're telling the robot where to start. And this is telling us where to start. This is telling us how deep to go. And we know what these structures are. So this is the edge of the prostate. This is the beginning. So what we're doing here is moving the numbers and telling the machine what tissue to take out and what tissue not to take out. So you can see that we can move these anywhere we want in order for safety reasons. Now, this is exactly what happens. The device is inside. We have a high pressure water spray that's actually removing the tissue, safely removing it to the correct depth. And during the procedure, we can move this. If we think it's going too deep, I can move it up or move it down. This is an actual slow down picture of how this tissue is removed. And again, this is the artist demonstration, and it shows you that we can get exactly where we want to start and exactly where we want to finish. And by doing that, we can reduce any type of risk that will occur. We can reduce the risk of incontinence down to almost zero, the risk of ejaculation issues down to about 10 to 20%. The risk of erection problems is essentially down to zero. And so, and here is a nice view of this high pressured water spray opening up and actually resecting the tissue in a safe way. So again, we use it combines a camera imaging along with ultrasound imaging, and to allow us to get a real-time detailed three-dimensional map of what you want to remove and what we don't want to remove. And what this does is it leads us to avoid damaging any sensitive areas that would lead to any of the severe complications that can occur. Just want to make sure that we did the whole. Yes, we did. Okay, great. Let's go to the next slide. This is actually a before and after. So you can see that there's a lot of obstructing tissue here. And again, this is the side view of showing where we tell the robot or the robot to actually resect. And this is the afterwards. And this is 3 months afterwards. And you just see a beautiful channel here. It's nice and smooth. And it stopped at this area here where we don't want to go any further, which gives us tremendous improvement. So again, this is done in the hospital under anesthesia. It takes about 45 minutes to do the whole procedure. You stay overnight. A patient will leave the hospital with the catheter, and we'll usually take it out that next day or the day after. Again, the post-operatively, there'll be some burning and urgency and some blood in the urine, but most of the patients do, quite well with this. And, it's pinpoint precision. We avoid the structures that we don't want to damage because those lead to side effects. The long-term results are like the TURP that we talked about before, but the complications are minimal to none. So it gives us the long-term and immediate tremendous improvement, which again works better than medications. The improvement works better than the UroLift and the Resume with a very little risk associated with it. And I just feel that it's fortunate. And here's the symptom relief. If you look at, again, that prostate symptom score, you can see it drops very quickly and it's lasts for a very long time. And I think that the benefit of this is that, again, we can remove the tissue, long-term effect with low risk. But each patient has to be tailored to the treatment that's best for them. Some patients will get tremendous improvement in the office with just the UroLift or the Resume with very little risk. They don't have to go to the hospital. I can do it here in 5 to 7 minutes. Other patients want a more long-term relief and improvement. And a lot of this depends upon the size and the shape of the prostate. So all the patients that come in looking for some of these therapies, we put them through a prostate ultrasound in the office so I could see the overall size, and a cystoscopy where I put a scope up through the penis in order to look at the orientation. So between the size and the orientation, I can help a patient and their preference. And that really is the most important thing, is what the patient's preference is as to what is going to be the best therapy for them, what they're looking for, what they want to try to avoid or not avoid, and get the most optimal benefit for them with the least amount of risk and involvement.